So why do we want to even know about autonomic drugs? Well, we use them in dentistry. So when we give local anesthetic, we're going to use something that's called epinephrine, usually that's added to our local anesthesia. And that epinephrine is going to be important. It is a catecholamine, and we'll talk about that in a second. So you'll get to understand what that term means. But it is part of autonomic drugs. Okay, so we need to know that. There's also drugs that we can give patients to increase salivary flow and to decrease salivary flow. Why would we want to even decrease salivary flow? Does anyone have maybe an idea? Just a guess. Do we have any assist? Oh, go ahead.
So that the mirror doesn't stick to the oral mucosa because when it gets dry, it's sticky?
Well, so I'm thinking of, we may want someone to have a dry mouth if you're going to do a procedure. Well, we won't do a procedure, but if the dentist does a procedure that calls for a dry field, right? If you have somebody who has a lot of saliva and you've got it, you're doing some sort of a restorative procedure and you need to keep it dry, you could give the patient, a drug that would cause them to have reduction in salivary flow. I don't know that really happens. Sorry. Yes.
So it should salivary flow in the slides, right?
What? I'm sorry, say it again.
Like we want to decrease the salivary flow, and so it should be to decrease the saliva flow.
Well, we have two different types. We have two different autonomic drugs. We have one that will increase the salivary flow. So that'll be good for, yes, our patients who have dry mouth xerostomia. And then there's also another drug that will decrease the salivary flow. So we'll see both of those. But I know what you're saying. You were talking about increased salivation. All right. These drugs will also be on national boards. So ultimately, we need you to be prepared for boards, right? I know we talk about that all the time, but I'm just trying to get you in the board mood. Be prepared for what you're going to see. All right. So we all know about our autonomic nervous system, our ANS, right? It's going to regulate our blood pressure, our heart rate, our GI tract motility, salivary gland secretions, bronchial smooth muscles. This is our fight and flight, and then our rest and digest, right? And so you guys remember this from, I almost forgot to stop my video because when we play this again, you're going to see my face the whole time. Well, I can't figure out how to do that now from this part. So I guess you guys are going to see my face the whole time. Sorry. Okay. So we have two divisions. We have our sympathetic, our SANS, that's our, fight and flight. So I always think about this, like if the, what do you call it? Has anyone ever watched like the Walking Dead series or like, World War Z or whatever? I would be the one running, you know what I mean? Like, that's what I think about. I'm running for my life. And I think about the SANS. And then parasympathetic is our rest and digest, when we're relaxed and kicking back and we're not feeling like we're in any kind of danger. So to really understand autonomic drugs, you need to understand these two divisions and how they react on our body systems, like what they cause our bodies to do when they're activated, because that will help you to understand the drugs much more clearly. You've had this in your bio class, so this is probably just a review, but we're going to talk about it again. All right. Let's see here. So in our autonomic nervous system, we're going to have our preganglionic portion of the nerves and our postganglionic portion of the nerves, and then whatever effector organ that we're going to affect. When we're reading questions for these quizzes, make sure that you are reading if it's preganglionic or postganglionic, and we'll talk about that in a second because it's important to know. We have preganglionic fibers of PANS. So they are going to originate from our cranial nerves 3, 7, 9, and 10. And then we're also going to see portions originate from the sacral S2 to S4 segments of the spinal cord. So when I think about preganglionic fibers of PANS, I think it's going to be at my head and at my base of my, at my butt, basically, right? So that's where those originations are coming from. Acetylcholine is our neurotransmitter in PANS. You're going to need to know that. You're going to need to circle that. It'll definitely be asked to you at some point. You need to own that. And we're going to talk about that even more. This picture is a bit fuzzy, sorry. But this just kind of is all I want you to see here is basically here's your sympathetic, here's your parasympathetic, where it's originating from. So we see our origination from those cranial nerves and the sacral, and then in the sympathetic, it's all from our core. It's easy for me to remember this because I think if I'm going to have to fight somebody or if I'm running from somebody, I'm going to have to use my core muscles, right, to either run myself away or, giving some action. So that's how I remember sympathetic originates from my core. And then the rest and digest is from our head and our sacral. All right. So again, then we have our sympathetic autonomic nervous system, and we're going to originate from our core, our thoracic T1 to the lumbar L2 portion of the spinal cord. Our big pieces, all right, I don't want to say pieces. How do I say this? Our what's released for our SANS is epinephrine and norepinephrine, right? So we need to know that that's what's going to be released from our postganglionic portion of the nerve to activate our SANS, to activate our fight and flight, all right? So our adrenal medulla is innervated by the sympathetic preganglionic fibers. So when you stimulate SANS, that's where our adrenal medulla is going to release more epinephrine and norepinephrine. Have you guys ever felt that situation where you were in a fight or flight and all of a sudden you have that rush of nervousness, right? You feel your heart pounding, your mouth's going to dry up, and I've been there before. All right, so this is just a clearer picture of the origination of both the SANS and the PANS, right? But it also kind of tells you what's going to be happening when it activates those effector organs or areas in your body. So as you can see, it's the opposite, right? You have the opposite action. If when you're in rest and digest, you've got constricted pupils, when it comes to fight and flight, you're going to have dilated pupils. This all makes sense to me because, again, if I'm running away from something in the dark, I'm going to need my pupils to dilate so I can get as much light in and be able to see where I'm going, all right? So what you need to remember and what you need to know is honestly what's happening to your body when you activate PANS and when you activate SANS. And if you know this, the next part is going to be much easier. Are you guys still with me, or are you just doing okay? All right. I missed my two screens because I'm trying to look at you and look at the chat and look at the PowerPoint at the same time. All right. Here's an important piece. So yeah, let's focus on this. Let's take some notes on this. We talked about our preganglionic nerve and our postganglionic nerve, right? So no matter if it is the sympathetic down here or the parasympathetic, between each pre and postganglionic nerve is a nicotinic receptor. And that nicotinic receptor is activated by acetylcholine. So if I were to ask you what activates between the preganglionic and the postganglionic nerve at the nicotinic receptor, what neurotransmitter would that be? You guys look just so tired.
Acetylcholine.
Thank you. Acetylcholine. That is something you need to know. So regardless if we're looking at PANS or SANS, parasympathetic or the sympathetic division, you will still have acetylcholine as your active neurotransmitter between our preganglionic and postganglionic nerve. That does not change. What changes is what is going to be our neurotransmitter, which is going to affect our effector organ, right? So for our parasympathetic, it's the same. It's acetylcholine. So ACH stands for acetylcholine. And when it acts on that receptor from that end, it is usually a nicotinic or a muscarinic receptor. So both nicotinic and muscarinic receptors are going to be activated by acetylcholine. That's what turns them on. They have receptors that acetylcholine fits right into. Oh, am I roboting it?
Yes, just not your voice, but it's kind of, I don't know, with you talking.
Is it my video or just or my voice?
Like I can hear you fine, but there's like a
Like an
robot-y
echo.
effect. Yeah, an echo, kind of like.
Okay, well, I'm gonna give somebody, let me make somebody I'm gonna hop on, hop back off, because sometimes that works. All right, Courtney, I'm making you the host. I'll be right back, guys. How about now? Is that better? Okay. So Courtney, if you could just make me the host again, I'd appreciate that.
I think it switched back to you already.
Oh, thank you. Okay. All right, let's see here. I'll go back to my from current slide. Okay, now what was I talking about? I lost my mojo here. What I was talking, okay. So we talked about acetylcholine is going to be the effector on the muscarinic and nicotinic receptors at the postganglionic receptor site, right? Oh yeah. So acetylcholine would be the neurotransmitter that's going to fit. If you guys remember that picture on page, let's go back and take a look in chapter 2, I think it was. Let me look. Page 13, chapter 2. Remember that receptor in the drug, right? The neurotransmitter is going to fit into that receptor just perfectly, and it's going to activate whatever response is meaning to be activated for the PANS in that area. Now the sympathetic, if you look at the postganglionic nerve, where's my cue? It's going to be acting on alpha-1, beta, and beta-2 receptors. We'll talk about that in a second. And its neurotransmitter is epinephrine or norepinephrine. So that may be something that's asked to you. You could have a quiz question that asks you, at the sympathetic postganglionic receptor site, what would be the neurotransmitter that is going to activate that receptor? And that would be anybody?
Norepinephrine.
Thank you. Thank you. So something to study for this and to really look at is what is the neurotransmitter between our preganglionic and postganglionic nerves, and that at each receptor site for the sympathetic and the parasympathetic, what is going to be our neurotransmitter that's going to affect that junction. Okay? All right. Another thing to note is on our parasympathetic, we have a longer preganglionic nerve and a shorter postganglionic nerve, and it's opposite for our sympathetic. Something that's different between those two that we would need to know. This is all in your textbook. So that's on page 34 to help you to study that. I like pictures. Pictures help me. All right. This is just a chart that talks about sympathetic and parasympathetic stimulation and what's happening on each of these structures again. So you guys can take a look. If you know this, it makes much more sense when we talk about cholinergic drugs and adrenergic drugs, because you know that they mimic, you know, either the parasympathetic or they mimic the sympathetic. Okay. And this is just that same chart in your textbook. And I can't remember, looks like it's on page 33. All right. So we know that the pans and sands act in opposite. It's like the yin and the yang, right, of our body. So pans is going to be concerned with conservation because you're resting and digesting, right? And sands is going to be designed for emergencies. We talked about that, fight and flight. All right. Most body tissues are innervated by both, but not all. So it's not an all or none statement. All right. We've talked about neurotransmitters a little bit. I probably got ahead of the game on my PowerPoint, but we'll just go through it again because we need to know these. So neurotransmitters are basically what is activating the response that we want, right? Our autonomic nervous system relies on 3 neurotransmitters and receptors to target tissues to regulate those physiological responses. And so our neurotransmitters are going to be acetylcholine, norepinephrine, and epinephrine. And acetylcholine is going to be activating 2 receptor sites. Can someone tell me what are the 2 receptor sites it's going to activate? Abby, you're making me jealous because you look so comfortable. I love it. Anybody?
Nicotinic.
What was that?
Are you asking for the nicotinic ones?
Yes,
or?
nicotinic or muscarinic is going to be our activated receptors, yes. And where will we find those receptors?
At where the preganglionic meets the postganglionic?
Yes, on both of them, on both the pans and sands, you're going to see that at the activation site will be between the pre and the post. You're completely correct. Very good. And then there's one other.
The muscarinic is at the neuroeffector junction.
Yes, of which one?
The pans.
Perfect. That's exactly right. And then when we think about norepinephrine and epinephrine, there's going to be a few receptors, right? Depending on where it's at in the body, right? We've got our alpha 1, beta 2, right? And where is that going to be associated with pans or sands?
Sands.
Beautiful. You guys see, you're getting this. You guys are getting this. So we know PAN's neurotransmitter is acetylcholine. It's termed cholinergic. Sorry, I'm getting tongue-tied here. So cholinergic, this is just my own way to remember this, but do you guys remember learning about cholera? It was a disease. I think it still happens today in probably third world countries. It causes massive diarrhea, right? When I think about rest and digest, you're going to have a more modal or movement happening in your digestive system. So cholinergic, I think of the rest and digest, and I think of cholera. I don't know why, but that all sounds right to me. It makes sense. So cholinergic is going to mimic our PANS, all right? And yeah, what was I going to say about that? Yeah, so you're going to see meiosis, which is contraction of the pupil. You're going to see bradycardia and decreased blood pressure because you're resting. You've got bronchoconstriction, increased respiratory secretions. Salivary glands is going to stimulate salivary glands because when you're digesting, you got to have more of that salivation, right? It's going to allow for urination and increase mobility in our digestion. So that's what to remember about that. And we know acetylcholine is released between those pre and postsynaptic nerve fibers because we just talked about that. It's going to activate those nicotinic receptors and it can cause skeletal muscle contraction. We saw this picture already, so I'll keep going. So here is question number 1 today for you. Anticholinergic agents Is this the right one or did I put the wrong one in there? I did, okay. Prevent the action of acetylcholine at the blank endings. We're almost there. 28 of 36. All right, perfect. Let me share the results. You are right. It's at your acetylcholine is at your postganglionic parasympathetic. That's right. Very good. Okay. So let's talk about the different types of autonomic drugs. We've got cholinergic. It's also called a parasympathetic mimemic. I'm again, try to say that 5 times fast. Parasympathetic mimetics, sorry. And it mimics, you see how mimics is in the end of that? It mimics our parasympathetic. That's basically what that's saying. So cholinergic is going to activate whatever that PANS activates. And then we have anticholinergic, which is a parasympathetic, parasympatholytic. LYTIC means to break down. So if you think about it, they're going to break down any of that acetylcholine so you don't have that PANS reaction. This is how I have to remember stuff. I have to remember what things mean, and then it helps me to remember the action of the drug. So that would be my suggestion to you. You may have another option, another idea of how to remember it, but that's how I remember it. They're also called cholinergic blocking agents. So you can see those 3 terms. Then we have adrenergic. Those are our sympathetic mimetics. That means they mimic our sympathetic system. So whatever you activate with your fight and flight, that's what you're going to get with adrenergic drugs. And then we have adrenergic blocking agents. Again, sympathetic, meaning they break down the adrenergic activators. Okay, or it could be, but they're the blocking agents. All right. So let's talk about cholinergic agonists. We learned the term agonist last chapter, right? So it's gonna activate the cholinergic system. It mimics the action of PANS. And they're usually going to be direct acting or indirect acting. And we'll talk about that in the next slide. But direct acting means it just acts exactly like acetylcholine. It's going to mimic that at the receptor site and turn on that receptor. Pilocarpine or Salogen. Pilocarpine, I know I have it capitalized here, but pilocarpine is actually the generic term, and Salogen would be the trade name. If we remember, we learned about that a couple weeks ago. That can be used in dentistry to activate salivary flow. So if you have a patient who has some severe xerostomia, that might be something that could be used to activate or produce more saliva flow for that patient. We also have indirect acting, so it inhibits the cholinesterase. All right, so what the heck is cholinesterase? ACE, anything that ends in ERACE, is going to be, it's going to break down, right? It's going to be an enzyme that breaks down. So cholinesterase breaks down acetylcholine. So if you inhibit the enzyme that breaks down acetylcholine is going to build up, right? And you're going to activate that response. Does that make sense? Give it a second. You might need to look over it, let it sink in a little bit, but that's what that means. All right. I got this from a different textbook. This isn't your textbook, but I like pictures. Oh, go ahead. Is that me again? Am I echoing? All right. So how do cholinergic agonists or anticholinesterase drugs work? So think about this as being your direct acting and this being your indirect acting, right? So your direct acting is going, this is our drug, it's going to pop right into the receptor and it acts just like the acetylcholine and it submits that response that we're looking for. And then anticholinesterase drugs or indirect acting cholinergic drugs are basically going to inactivate that enzyme that's breaking down the acetylcholine so the acetylcholine can activate that receptor itself. Does that make sense? All right. So here's question 2. Let me pull my polling up again. Do we like the questions? Do those help? When different drugs compete for the same receptor sites, the drug with a stronger affinity for the receptor will bind to one more. All right, I'll end polling. I just missed one person. Yes, more receptors in the drug than the weaker affinity. Again, see how we're building on this information and we're adding it to what we're learning now. All right. So what are the pharmacological effects of these cholinergic drugs? Well, they can affect the cardiovascular, both direct and indirect actions on the cardiovascular, but our cardiovascular heart rate effects are going to be a negative chronotropic action. You need to know what negative chronotropic action. You're going to see that on the board. It slows the heart rate. And then the negative inotropic action decreases the force of heart. So we're going to have a decrease on the cardiac output overall. All right. It causes vasodilation of the smooth muscle around the blood vessels. So we're going to see a decreased peripheral resistance. We see I can't, I want to see you guys, but then I can't see what we've got GI effects. So we're going to see more modal GI effects. So we're going to produce more activity in that area. We're going to see more motility, more secretion. So a patient is likely to experience diarrhea with a cholinergic drug. We're going to see eye effects. We're going to see the meiosis, contraction of the pupils, and it reduces inocular pressure. So this is something, and I don't know why, but you may be asked about cholinergic agents used to treat narrow angle glaucoma. I don't know why, or glaucoma. They do. We can use cholinergic agents to treat glaucoma because that intraocular pressure is decreased. It's like glaucoma is like high blood pressure of the eye, right? So how I remember that is that if you're in rest and digest, I just think the pressure's off your eye, if that helps you to remember that. Also, a little acronym that's very helpful is the term SLUD. So with cholinergic drugs, you're going to have increased salivation, increased lacrimation, increased urination, increased defecation. So SLUD, and it sounds kind of like it means, right? You're increasing all those areas. You can also have neuromuscular paralysis with larger doses of cholinergic drugs. So if we have an overdose of a cholinergic drug, we do have treatment for that. If you turn to page, where is it at? Well, before we get to that, I don't want to forget to mention, if you look on page 35, table 4-3, there gives you a table of your cholinergic or your parasympathetic mimetic agents. So make sure you know that. And yeah, okay. So we can have a combination of pralidoxime and atropine. Atropine is something that can be used to cause xerostomia, so it's going to give the opposite effect, right? Or pralidoxime can regenerate the acetylcholinesterase enzymes, and we know acetylcholinesterase is going to break down what? I mean, it's going to break down our acetylcholine, so then it was going to reduce that increased acetylcholine that's causing that reaction, okay? All right, what are some contraindications to our cholinergic drugs? If you have bronchial asthma, it can cause a bronchial spasm or asthmatic attack, so you wouldn't use it then. Hyperthyroidism, because it could cause atrial fibrillation. GI or urinary tract, if it's already obstructed, we wouldn't want to give something that's going to increase the motility and secretions, or you're going to have more pressure at that backup. Also, it can increase severe cardiac disease or reflex tachycardia. Myasthenia gravis, this part is confusing, so try to stay with me here. Myasthenia gravis is treated with neostigmine, an irreversible cholinesterase inhibitor, because neostigmine occupies the enzyme and the irreversible agent would not function. So that one I think is kind of confusing. But you also wouldn't use it with a peptic ulcer, because again, if you're resting and digesting, you're producing more acidity in your stomach to digest, and that would be an issue with an ulcer. What can we use these cholinergic drugs for? Well, the direct acting can be used for glaucoma, because we talked about that. It can reduce that intraocular pressure, that hypertension of the eyes, like I think about it. You can use it for myasthenia gravis if you use a reversible indirect acting cholinergic drug. Neostigmine is a reversible indirect acting. We just can't use an irreversible cholinergic drug with a myasthenia gravis. And you could use it for urinary retention after surgery, so that you're able to go to the bathroom after they give you drugs not to. And pilocarpine, this is something you need to know, or Salogen, is used to treat xerostomia in dentistry. People don't actually use it that often because it does have side effects that are, not going to be beneficial, but it can also be used to treat glaucoma. All right. We talked about, what the heck? Hold on, guys. There we go. We talked about physostigmine. It's a cholinergic drug that acutes toxicity of anticholinergic drugs. So you wouldn't want to use it with a drug that has the same action. So you wouldn't use it with antihistamines or tricyclite antidepressants or phenothiazine, because it has the same action. You would never want to double down with two drugs that cause the same action, okay? All right, so there are irreversible cholinesterase inhibitors. Remember, what is cholinesterase? When I say cholinesterase, what does that mean to you? It means it has to do with enzymes, right? Cholinesterase has to do with enzyme, yes. So there's irreversible, basically, acetylcholine enzyme that breaks down the acetylcholine, right? Cholinesterase breaks down the enzyme, the acetylcholine, right, inhibitors. So if it's developed for insecticides, chemical warfare against, like pralidoxime can be used to counteract sarin nerve gas. Parathion and malathion are going to be chemical warfare agents. All right, so what are our considerations as dental hygienists? Make sure we're using good oral hygiene, may have increased effects of salivation. Salvation's good, right? But what might be an effect of increased salvation when it comes to dental hygiene? When it comes to us, what we want more salvation, right? What might be a concern with increased salivation? It's not really a concern, but what can increased salivation cause in our mouths? I might not be asking the question correctly, but basically it's going to increase our calculus, right? So that's probably what I'm thinking. You know, make sure you're really removing that biofilm because you're going to have an increased risk of calculus formation. That's what I think of when I think about that. Be mindful of patient positioning. Hypotension is a side effect of cholinergic drugs. So that just means we're not going to, you know, put someone up quickly in the chair, right? We're going to be careful, let them sit there for a second before we move them out of the chair. There are many side effects with pilocarpine, and those are perspiration, nausea, rhinitis, chills, and flushing. So that's why we don't prescribe it often, because no one wants to profusely sweat, right? Or have a runny nose the whole time. You know, chills and flushing would not be a positive either. But pilocarpine can also be used to treat glaucoma. It is a cholinergic drug and it can be used to treat glaucoma. All right, let's talk about anticholinergic agents. So we know they're anticholinergic because we are preventing the action of acetylcholine. So we're increasing those enzymes that break down the acetylcholine and blocking those muscarinic receptors from the activation of acetylcholine. All right. So they're going to reduce the flow of salivary secretions. So how might a drug be used in dentistry? I already asked this question. I got ahead of myself. To reduce salivary secretions. I asked it before. If you have a procedure where you need a dry field, you may have your patient take atropine before they come in. That way their mouth is nice and dry. Then you add in, you know, maybe a, oh, why is this not in my, I can't think of it. Help me out here. We isolate the area with a, I can't, it's not coming to my head. We learned about it in this summer.
Rubber dam?
Thank you. Yes, I'm like, why can't I think about it? Yes, rubber dam. Maybe you'd use atropine and a rubber dam to keep that nice and dry. So that's how we might use that in dentistry. Here we go. We're going to see some relaxed, smooth muscle in the respiratory tract. So we'll see bronchial dilation, which would be beneficial for somebody with asthma, right? So these anticholinergic drugs can be used for asthmatic patients. We're going to relax smooth muscle the GI tract. So we're going to decrease the GI motility. And so if we overuse it, it can cause constipation. That's one of the kind of the downfalls, or maybe we want to have constipation. Spasmolytic agents are drugs that reduce those spasms in the smooth muscle. So we can reduce spasms in our cramping in our smooth, in our intestines with anticholinergics. And it's going to cause mydriasis. It's going to dilate. I always remember mydriasis is dilate because it's got the D in it. So if I see meiosis, I think, oh, okay, that doesn't have the D. It's going to make pinpoint pupils. All right, that's how I remember that. If you give large doses of anticholinergic drugs, you can produce a vagal blockade, which results in an increase or tachycardia. So sometimes you could use that during surgery, or they would use that during surgery. We wouldn't, but like if you had a person who is going in general anesthetic, because that general anesthetic can slow the heart down too much, that's going to do the opposite effect and help to bring that heart rate up. And this is where it gets confusing. So write this down. Anticholinergic in large doses can result in tachycardia, but in small doses, it's going to result in bradycardia. That's what you're going to see. That's going to be the predominant effect. It's kind of opposite, but you need to know that. I'm sure you'll be asked that. Anticholinergic drugs can have both effects depending on the dose of the drug. All right. Who is still with me? Are you guys asleep yet? Or is it just so riveting that you can't fall asleep? All right. What are some of the adverse reactions? Well, we know that it can be used to decrease salivation. So xerostomia is going to be a big issue. Blurred vision because it dilates your pupils. Tachycardia, fever, urinary and gastrinal stasis, meaning nothing's moving. Hyperprexia and hot, dry, flushed skin because you're not sweating because we're reducing that, perspiration. And we can see signs of CNS excitation. So are some of the adverse reactions. So when would we not use it? We would not use it for glaucoma, narrowed angle glaucoma. This is something to know. I would write this down right now. I don't know why, but this is a question you may be asked on a quiz, a test, or on the boards. But somehow we need to know that anticholinergic drugs are contraindications for narrow angle glaucoma. Anyone who has a enlarged prosthetic gland, we wouldn't want to give it to because of urinary retention. It decreases mobility. So if you have intestinal obstruction, we wouldn't want to give it. If you had urinary retention problems, we wouldn't want to give it. And for specific cardiovascular diseases, it can block that vagus nerve again and cause tachycardia. So or if you give a slow, depending on what cardiovascular condition, we wouldn't want to give it. All right, when would we use this? Preoperative medication, because like I said, it inhibits secretion. So we could use it, before general anesthesia. You could use it in treatment of GI disorders because it decreases the motility and acid secretion. It dilates the pupils, so you might use it for an eye exam. This one's important. It does reduce Parkinson-like movements. So it can be used with levodopa to reduce Parkinson's symptoms. And it can be used for motion sickness. There's a transdermal patch that's used for motion sickness. It could be used. That's example there. All right, what about drug interactions? Most important drug interactions is associated with anticholinergic agents is additive anticholinergic effects. Again, we do not want to double down on the same effects because that can cause an issue. So anticholinergic drugs plus antihistamines, tricyclide antidepressants. Anticholinergic toxicity would include urinary retention, blurred vision, and acute glaucoma. You just don't want to mix more than one drug group possessing the same effects because it can lead to toxicity. And what are our considerations? Xerostomia. Why do we care about xerostomia so much? We're going to hear this so much in pharm. Why is xerostomia such a big deal to us? Caries, yes. Low saliva increases caries, yes. Caries form more easily. We're just going to be increasing our risk for caries, right? So we want to make sure if the patient's taking medications that cause xerostomia, we're going to practice meticulous oral hygiene. We need to make sure we're brushing, flossing, getting every cranny of that mouth, drinking plenty of water. We can use lozenges, but what kind of lozenges do we not want to use? Or what kind of gum do we not want to use if we have xerostomia? Or really any time. I see Crystal's lipping it. Yes, sugar. Yes, you're right. Nothing with sugar. This kind of is an issue with our elderly patients. A lot of times they'll take lozenges, just make sure they're using, sugar-free lozenges. However, that gets me on a whole nother tangent. Have you ever had an experience with sugar-free lozenges or, we used to keep them in our dental office and I was like, oh, these are so good. And I remember I had a horrific stomach ache because I got a little crazy with them. They cause these alcohols cause gas buildup in your intestines. It's not pleasant. So there's got to have a balance there. Make sure you're avoiding caffeine because that can dry out your mouth. Make sure we're using sugarless gum or candy. Anything with xylitol would be a benefit for our patients. We want to recommend a xylitol candy or a lozenge or a xylitol gum. Always check our pulse and blood pressure. We do that before we see our patients, and we're always going to do that before I see our patients because that's the safest way we can treat our patients. So we're going to be checking for tachycardia. We want to be considerate of sedation because we want to be cautious if we're combining with other sedating drugs that, you know, may cause the same effects, right? We'd advise patients to have a driver, and we don't ever want to make a life-altering decisions if we're under the effects of sedation. I don't know if you've ever been sedated maybe for your third molars or something like that, but you think you can make good decisions, but you're not going to remember them the next day. So don't make any life-changing decisions. All right, so here's a question. Your patient is complaining about a dry mouth, which is probably occurring from radiation therapy. He has been sucking on lemon drops to keep his saliva flowing. We already talked about this. What may occur and what could you prescribe for this patient? Anybody? Yes, pH decreases and caries. So our worry is from caries. Very good. And then what could we prescribe for the radiation therapy since we're drying out that mouth? Well, you definitely could have them do xylitol gum. Gum with xylitol is perfect, but there's a prescription we learned about that produces more saliva. What was that prescription? It's, to me, the prescription sounds like we're going fishing. I don't know why. Pilocarpine. I think it's carp. You know, there's a, I don't know. All right, very good. So let's talk about some helpful hints for remembering anticholinergic action. A, B, C, and D. Anticholinergic agents are going to cause blur vision, bladder retention, constipation, dry mouth. So hopefully that'll be a little helpful hint to remember those. All right, adrenergic drugs. We're almost done here, guys. Adrenergic agents are sympathetic mimics. They're going to mimic the fight and flight response, right? Our SANS. So they're going to mimic the SANS fight or flight. And their main neurotransmitters are norepinephrine and epinephrine. Another term for adrenergic is, look on page 30, no, it's not 37. Hold on. On page 39, the term catecholamine, catecholamine, catecholamine. When you think about epinephrine is a catecholamine. So that might be another term that you see when we talk about adrenergic drugs. All right, so they're direct acting and indirect acting and mixed acting. So let's talk about that. Adrenergic can either directly act on those receptors, right? Plug right into the receptors and produce the effect. Indirect acting, so like amphetamines trigger the release of an endogenous norepinephrine producing a response. So it triggers us to produce our own norepinephrine and produce that same response. So it acts indirectly on our body. And then mixed acting, like ephedrine, it can stimulate receptors to directly or release endogenous norepinephrine to cause a response. So it can either, some of it will work on directly producing that response, and part of it will work on us producing that neurotransmitter to produce that response, if that makes sense. I'm getting tongue-tied again. All right. This is a great picture, again, not from your textbook, but I found it from another textbook, and I think that's helpful. It shows direct acting, indirect acting, and mixed, if that makes sense and helps you to look at that. I like pictures. All right, so what are adrenergic drugs going to do? They're going to have CNS excitation, alertness. Higher doses can cause anxiety, apprehensive, and restlessness because you've got all that androgynous hormone kicking in, right? So what type of receptors? We talked about this. They're going to work on alpha receptors and beta receptors. Alpha 1 receptors are located in our eye and arteries. So they're going to cause the mydriasis, that pupil dilation, and vasoconstriction. That's why we use epinephrine in local anesthesia. It constricts those vessels so that we keep more of that local anesthetic in the tissue around the nerve instead of pulling it into the distribution piece and then not being able to keep that patient numb. So I remember it works on alpha-1 because of that. Then we have our beta receptors, 2 types, beta-1 and beta-2. Beta-1 is 1 heart, 2 lungs, if that helps you remember that, right? So 1 equals 1 heart, 2 equals 2 lungs. That's how I remember that. Now, do you remember our chronotropic effects on our heart? When we look at the effects, we're going to have a positive chronotropic effect. So we're going to increase the heart rate, increase the heart force. So we have an increased cardiac output and that makes sense because you're, fight and flight action, right? You're going to be, your heart's going to be pumping and you're going to be running. And again, beta-2 receptors are going to work on our smooth muscles of the bronchioles in our lungs. So they're going to stimulate vasodilation of blood vessels and bronchodilation in the lungs. And again, the way to remember that is we have 2 lungs, beta-2, 2 lungs. It works on our lungs. So what are some of the pharmacological effects we're going to see? We're going to see, we talked about increased heart force and contractions. We're running, right? Our heart's working hard. It's going to increase peripheral resistance. So you're going to increase your blood pressure. That makes sense again, because we're running, our blood pressure, we're scared our blood pressure is going to rise. What else? We're going to decrease intraocular pressure. So we can use these drugs to treat glaucoma. Again, I don't know why you need to know why we're treating glaucoma, but you do need to know it. We can use these drugs in the treatment of asthma and anaphylaxis. When we're talking about emergency situations and someone's going into anaphylaxis, what are you stabbing them with? What are you going to give them? You're going to use an EpiPen, right? You're going to get them with the EpiPen, and that's epinephrine. So that's why that makes sense. One thing to know, and I have it bolded here, is hyperglycemia. We're going to see increased glycogenolysis, so breakdown of glycogen in the liver, and decreased insulin resistance. So it can cause hyperglycemia in the blood. That's why when we have a patient who is diabetic in our chair, we're always worried about we're not worried, I don't want to say that, but we're always mindful of how much epinephrine we give them because it can cause more sugar in the blood. We can see hyperglycemia from that, okay? I know this is a lot. You guys are doing great. And we know it causes xerostomia because you're running away and everything's drying up. All right, adverse reactions. Again, if we have too much, we can have anxiety, tremors, palpitations, serious arrhythmias, dramatic rise in blood pressure. I think about, have anyone ever had an epi reaction after they had local anesthesia and your heart feels like it's racing? So you might see some palpitations with adrenergic drugs, all right? Some contraindications, we're not going to give it to someone who's at uncontrolled hypertension because it's going to increase that blood pressure. Angina because it constricts, so that's not going to give enough oxygen flow. Hyperthyroidism because of atrial fibrillation, and this can lead to arrhythmias, and it can lead to a myocardial infarction. What do we use it for? Vasoconstriction agents, so we're going to see that, with local anesthesia, right? Anytime we want prolonged action with local anesthesia, we want hemostasis. So we want to reduce blood flow. If you put it locally in an area, you can see some hemostasis or reduced in bleeding. Sympathetic mimetic agents are used in nose drops and sprays to treat congestion. So it helps to reduce those vessels and the mucous membranes and the inflammation in the nose. We can see it in decongestants. We see it in the treatment of shock and treatment of cardiac arrest. Epinephrine is given, and also in anaphylaxis, right? We're going to see that used in anaphylaxis. Oh, I had that on this sheet. Raise bronchodilation, so they can be used as bronchodilators with asthma and COPD. So asthma, emphysema are treated with adrenergic agents. Epinephrine drugs can be used for anaphylaxis, which we talked about. Amphetamines are going to be in this category as well, and they are known to be abused for staying awake or diet pills or to produce that euphoric effect. Ritalin are adrenergic agonists, and they can be used to treat ADD. All right. We talked about epinephrine. That's going to be for asthma, anaphylaxis, cardiac arrest. Let's see here. Phenylephrine or as nasal spray, again, for congestion and helps with that vasoconstriction. Levo is basically a synthetic epinephrine, and that you're going to see in our local anesthesia, local agents as well, certain local agents, I should say. And ephedrine is actually no longer sold in the US. It's not available for dietary supplements, but that used to be a diet drug. Pseudoephedrine, you can get over the counter. You know, you can only get so much of it because it's actually used to make meth illegally. So you can it's limited on the amount you can purchase, and you have to be 18 to purchase it. But it is used in, you know, decongestants, right? For decongestant agents. All right. What are our dental hygiene considerations? Like always, we're always going to take blood pressure and pulse. We always take a detailed medical health history. We may have to use lower doses of vasoconstrictor or even not use vasoconstrictor depending on that patient's health history. Now we go into adrenergic blocking agents. We are doing good on time. I'm so excited. I'm trying to keep my clock here. That way I keep myself moving. So it does what it says, right? We're going to block that SANS effect. So adrenergic agents can block all adrenergic receptors. I forgot an R on the receptors. That should be receptors, or select only the following. So we can have ones that are selective or non-selective, if that makes sense. So we can have alpha receptors referred to as alpha blockers. Beta receptors are referred as beta blockers. We're going to learn a lot about this in the cardiovascular unit. And we're also going to see it in drugs that treat like asthma, COPD, and so on. All right, adrenergic blocking agents, they're going to inhibit the vasoconstriction effects of the adrenergic agent. So we're going to see epinephrine reversals. We can see that, block mydriasis, phenyloxybenzamine and phenylalanine are both alpha blockers, and they're going to be used to treat peripheral vascular disease or Raynaud's syndrome. Do you guys know what Raynaud's syndrome is? Does anyone know? Usually it's you see it peripherally, like in our toes and in our fingers. You'll see where people's fingers are like bright white because they just have a lack of circulation. So this is going to help to increase peripheral vascular movement and get more circulation to the areas that are not able to have blood circulation. I feel like that was big. I feel like my daughter came up and she's like, "What? Why is my toes always like bright white?" I'm like, maybe you have a little bit of Raynaud's or something. Who knows? Okay. Adrenergic blocking agents, tolazone, prazosin, tazarsin, doxazosine, Cardura. That's the one that sticks with me the most. It's a cardiovascular drug, and you're going to see that more often for hypertension. So all effective in treating hypertension, Raynaud's disease, and treatment of prostatic hypertrophy, so enlarged prostate. All right. So what are these used to treat? Hypertension. Well, that's why we're going to see these in the cardiovascular unit. Angina, arrhythmias, migraine prevention, glaucoma. People with asthma we're going to use caution when prescribing because it may cause bronchoconstriction if we have the adrenergic beta blockers. Oops. All right, so we have beta blocking agents. Again, we're going to talk about this again. So if we know it now, it'll be better when we go to cardiovascular unit. But beta blockers, the generics are going to end in OL. That's how we can remember beta blockers, end in OL. They usually cause bradycardia. We really want to be understanding of specific or non-selective and selective or specific. So specific beta blockers will have more activities on the heart, blood vessels, and on the lungs, and the specificity you know what I'm saying? The specific, anybody want to help me with this word? Because I'm not going to be able to say it now. The specificity. Okay.
Specificity.
Yes. Thank you. Specific. Okay. You said it. Produces fewer side effects, and they're going to have less drug interaction. So remember, if we're acting on one specific area, then we shouldn't have the non-target organ, reactions that we have with other drugs. Does that make sense? Okay. So you're going to hear about propranolol, atenolol quite a bit in the cardiovascular unit. So they are beta adrenergic blocking agents. So you need to know those. Some of them have alpha and beta blocking agents. Okay, so Trandate is one of those. Alpha and beta blocking agents are going to end in ALOL. That's their generic ending. Now, that doesn't mean all. I wish it does. I wish everything just had a specific, and that there'll always be a few outliers of that, so be prepared for that. All right, and these can be indicated for treatment of hypertension as well. All right. So what are general considerations of patients taking adrenergic agents? Blood pressure, we talked about this actually when we did that one. We talked about this too as well, didn't we, under anticholinergic? Yes, we talked about that. All right. What about considerations for beta adrenergic drugs? We talked about that. Here's question 3. Let's do our polling question. Which of the following categories of an ANS agent would you use to treat patients with narrow angle glaucoma? And I got to launch it. Sorry, guys. If this helps, if you look on page, there's several different tables, which will be helpful. We've got page 35, which has table 4-3. We've got table 38, which has got, page 38, which has table 4.4. And then we have table 40, which is 4.5. And then page 42, which is table 4.6. Those are going to be some of the examples of those drugs. All right, I'm going to end. Are we good? I'm missing 6, but okay, here we go. All right, so let's talk about this one for a second. There's several drugs that can treat glaucoma, right? Cholinergic drugs can treat glaucoma. Adrenergic drugs can treat glaucoma, right? Is there one that's specific for narrow angle glaucoma? Courtney, you say anticholinergic. Where would we find that? All right, page 37. You got it. Page 38, right? Very good, very good. All right, that was kind of a tricky question, but that probably will be something that you see again, honestly. Okay, well, for the first time, I'm ahead of the schedule and not 5 minutes past, so that's good news. Let's talk about questions. How do you feel? Is it understandable? Is it not understandable? I'm like, I have no idea what's going on, or that was pretty good. I felt like it built on what you knew. How do you feel? I'll put my chat up here. Yeah, you do need to read. It's something you have to read and go over. But one thing I want to share with you, this is a lot. It's a lot. I'm telling you, if you guys break it up into small digestible chunks, it's going to be a lot better. Don't ever try to cram for this class because it's not going to work. But I do want to share with you. Oh, I can start my video now. I do want to share with you if you guys look real quick onto Cobra, I put in the content area, should be a chapter 4 drug list. If you go on to Evolve, you have access to all these drug lists. I'll try to remember to put them on each week, but it goes over and it breaks down. Let me just share this with you. It breaks down a quick drug guide basically for you. We got pilocarpine, right? We have pilocarpine is the generic name. I know these are all capitalized, but these are the generic names, and these in a parentheses are our trade names. You've got pilocarpine twice because we have two different, I don't know why they didn't just put those together. I don't know. Anyway, you got two different trade names on that one. Our anticholinergic agents and our adrenergic receptor agonists. Where are we missing? We're missing our blockers. I'll look online and see if there's another. No, I don't have those. Also, you can find these drugs in your textbook under the tables as well. Do you need to know these? You do need to know these. The reason you need to know them is not only for me, but it's like double fold. You will be asked to look at case studies and recognize drugs and recognize what those drugs are used for and what type of drugs they are. And they're going to ask you questions on that. So you do have to learn the drugs. I know it's a lot to remember, but they start to stick in your mind the more you look at them. Do we need to know them for next week's quiz? Well, I for sure would know. Let me look at my list here. Pilocarpine, atropine, Atrovent. We're going to talk about those again. And maybe what I could do is I'll revamp this and I'll highlight the ones that are the most important. Would that be helpful? Okay, I can do that. All right, anything else that would be helpful? How are you guys doing okay? All right, I'll add that one point on, I'll highlight that, post that, and I will post our recording from today. And if that's it, I'll let you guys go and I'll see you in about an hour. If you have any questions, feel free to stay on.